Assalamualaikum and a very good morning. I bid to Dr. Inas. My name is Ezza Hazirah binti Hussin and my matrix number is A174588. Today, I'm going to present a case report based on odontogenic keratocyst. So these are my table of contents. I'm first going to talk about the history, followed by the clinical examination, investigation, histology, diagnosis, treatment, and discussion. For definition, odontogenic keratocyst is a benign aggressive developmental cyst that arises from the cell rest of dental lamina. It can occur anywhere in the jaw but commonly seen in the posterior part of the mandible. So for history taking, a 28-year-old male came with the chief complaint of having pincer swelling in the right side of the upper jaw. The history of the chief complaint, the patient noticed that the swelling since a year ago and there was no previous history of extraction or previous infectious episode. For medical and family history are non-contributory. Next is the clinical examination. For extraoral examination, there was presence of slight swelling and tenderness over the right cheek and there's presence of induration of the nasal region while the integuments are normal. For intraoral examination, there's missing of right canine, tooth 1-3, with mild tenderness on palpation. There was no evidence of vestibular obliteration, expansion, or pus discharge. Patient has poor oral hygiene and the presence of calculus blocks. He also has generalized gingivitis. So for investigation, orthopantomogram was taken and it showed a vast unilocular radiolucent body with clear contours of within the maxillary bone and inserting itself in the collar of the impacted canine, extending transversely from the tooth 2-3 to the distal root of tooth 1-7, as you can see shown by the yellow arrows. Next, coronal sections of CT scan was taken and it showed a slight fragility of the floor of the nasal cavity of the left side and integrity of the maxillary sinus. Next, axial sections of CT scan was also taken and it revealed a greater extent of antero-posteriorly rather than bucco-palatally. Next is for the histology. Histopathological examination revealed a seized wall lined by stratified squamous epithelium and a corrugated parakeratinized surface. The epithelial lining is supported by a chronically inflamed connective tissue. This is another image of the H&E stain. The epithelial lining is composed of a uniform layer of stratified squamous epithelium, usually 6 to 8 cells in thickness. The epithelium and connective tissue interface is usually flat and the rete-radius formation is inconspicuous. The basal cell layer has columnar or cuboidal cells with reversely polarized nuclei, imparting a picket fence or tombstone appearance. The luminal surface shows a flattened parakeratotic epithelial cells which exhibit a wavy or corrugated appearance. Next is for the diagnosis. There are 4 differential diagnoses which are the odontogenic keratocyst and followed by the dentageral cyst due to the presence of the radiolucency containing the tooth crown. The third one is the adenomatoid odontogenic tumor because of the radiolucency containing an impacted tooth in association. And lastly is the ameloblastoma due to a unicystic image in relation with an impacted tooth. So for the definitive diagnosis is odontogenic keratocyst based on the histology that has been done. Next is the treatment. Enucleation and curettage can be done to treat this patient, followed by can also be done peripheral osteotomy of the cavity or chemical cauterization with Kino solution after the tumor removal, and there must be a long-term follow-up. Okay, so the pictures, the lower left picture shows the enucleation of the lesion, and the lower right shows the bone cavity after the enucleation has been done. Lastly is the discussion, and I'm going to talk about the definition and epidemiology, followed by the etiological factors, signs and symptoms, and the differential diagnosis. So, as I've mentioned before, odontogenic keratocyst is a benign aggressive developmental cyst that arises from the cell rest of dental lamina. It can occur anywhere in the jaw but commonly seen in the posterior part of the mandible, but unlike this case, it is seen in the maxillary rather than the mandible. It is more common in 20 to 30 years old patient. and is more frequently in males rather than in females, and commonly seen at the posterior angle of mandible and extend to ascending ramus and forward to the body of the mandible. So for the etiological factors, it is caused due to mutation, which is a deletion or inactivation of the tumor suppressor gene called patch gene PTCH on chromosome 9q. So for the signs and symptoms, the peak incidence, as I mentioned before, is around 20 to 30 years of age, which occurs in 60% of the cases. It is symptomless in early stages, and it is slow growth, mostly in the anteroposterior direction. Patient will experience pain and swelling in larger lesions, and there will be multiple odontogenic keratocysts can occur in patients with nevoid basal cell carcinoma syndrome, or known as Golin syndrome. So for differential diagnosis, the differential diagnosis can be obtained by asking the patient history and examining the clinical finding, which are the extraoral and intraoral examination, radiography such as the OPG or the CT scan, and histology for confirmatory. And I think that's all from me. Thank you.